And I posed the question of, can we predict AKI? And that's an issue we've been focusing on a little bit in our research. And most of the work that I'm presenting today has actually been done by Dr. Yunlin Feng, who's a Chinese nephrologist who's been doing a PhD with us, which she submitted yesterday. And she's been an amazingly energetic and thorough, and some of you'll see some of the work that she's done here and realise how much work she's done. So I'm going to touch on the history and the epidemiology of AKI, which has got some interesting aspects to it. And then I want to talk about what's been an explosion in AKI prediction models over the last 10 or 12 years and what the lessons are from that. So rhabdomyolysis was probably the first clinically recognised acute kidney injury syndrome or cause. But generally, there's a huge variation in the presentations of acute kidney injury. It's postulated that the first reference to acute kidney injury actually goes back to the Bible, and there's a reference there in the book of Numbers to the Exodus from Egypt, and the consumption of some birds, and as they were exiting Egypt, which had been eating some toxic plants, and there's widespread deaths associated with it. Most people recognise the beginnings of acute kidney injury really as being the reports in the BMJ in 1941 around crush injuries in World War II. It was known about before that, but it's really where it came into the most prominent settings. And then for me, I think the thing that's really characterised acute kidney injury has been radiocontrast. I can remember giving talks in the late 90s as a registrar around radiocontrast-induced acute kidney injury, which was first described in the 1950s following IVP. And of course, with the rapid expansion in contrast and radiological procedures, this has become a whole industry in itself. It's actually a whole talk, I think, radiocontrast-induced acute kidney injury. It's quite interesting at the moment because there's a reasonable number of mainly US radiologists who take the view that it doesn't exist. That might be true, but no one's going to prove that in a hurry, I don't think. So just to really illustrate the burden of acute kidney injury, this is from a Nature Reviews paper in 2018 and shows the spread of rates of AKI among hospitalised patients. And you can see it's somewhere between 15 and 25 or 30% across the globe. So it's largely a hospital-based disease, although there are community episodes of it, but the study is really focused in the hospital. This is US data looking at coding and diagnosis codes for acute kidney injury. And again, you can see there's been this inexorable rise in coding. Now, part of this, I suspect, is that we're now recognising it better. So maybe there was more AKI in the past than we realised, but still, you'll also notice that this is a breakdown by age group, and the higher age groups, as per usual, are those who have got the higher rates. Richard presented data yesterday on the frailty of patients in the clinical trials, and those frail patients whose blood pressure is at the margin of renal perfusion, it doesn't take much to tip them over. So a lot of those patients wouldn't have been surviving 15 years ago, and they are now. So there's this whole cohort of patients at high risk wandering around in our communities on polypharmacy and at risk. So the problem's not going to go away in a hurry. So getting to the prediction model work, our first toe in the water with this was around just sort of trying to understand how big the literature was. And the bar graph you can see there goes back to 1975 on the right and 2023 on the left. And it shows you a dramatic expansion in the number of publications. This is just a quick and dirty search of PubMed for AKI models. And a dramatic expansion in those models in the last 10 to 12 years. And we really came from this for trying to understand, well, what have we learnt out of that modelling literature? So the systematic review and meta-analysis that Yunlin led ended up with 150 papers in it. So it's a massive body of work. And and it included all settings, so contrast media, post-operative, ICU or general hospitalisation with a broad characterised subgroups. For anyone who's read much of this literature, there's widely differing variations, and perhaps the best illustration of it is the time point for acute kidney injury episodes. And people use 2 days, people use 5 days, people use 7 days, people use different creatinine rises. And I would argue that not all of them are the same apples that we're looking at. There's also real challenges in the quality of the data here. And I think it's really important to understand the relative value of retrospective versus prospective data. And this is a good illustration of it. I think a lot of people are using retrospective data sets to look at it, and the timing of some of those variables and when that information is available to clinicians is entirely unclear often. There's some external validation in around 2/3 of studies, but there's very little external validation of these published models. And generally they're at high risk of bias. So I just flipped to the issue of imprecision when you meta-analyse this data, which is something I hadn't really been aware of until probably 12 months ago. Because when you think of meta-analysis, you're bringing together data and you're getting more precision around your estimates. So you expect that the confidence intervals would narrow around those events. And generally that's true. So if you've got a literature of 150 papers, you would hope that you come out the other end of it with a pretty precise estimate of an effect size. But prediction models are a little different. So this is an earlier meta-analysis published in 2017 from a Canadian group. And it looked at the contrast-associated acute kidney injury models, and it found about 6 models. And you can see this, the summary estimate in the end was a very tight confidence interval around the estimate of 0.89. When you're looking at 150 papers, though, one of the things that struck me was that when Yun Lin developed this summary ROC curve, which allowed us to graphically present all the data. And you can see, so each of those dots is a trial or a model. And we had this huge variation in models, and some of them which were implausible, that they are perfect models and that's just not going to happen. So you'd have to be suspicious that some of those models are including variables that are post hoc, that are occurring after the exposure period. And I couldn't understand how we were getting all this disparate data. We were adding some very large data sets. Some of these are huge data sets. And then we ended up with these really tight confidence intervals. And we had lots of back and forth about it. And our error was that you need to handle these differently to a normal meta-analysis. You're getting a point estimate of a model. So in fact, you need to use the prediction interval, not the confidence interval, to interpret them. So when we did that, so the red dot there is the confidence interval, and you can see it's pretty narrow. So, you think the truth lies somewhere in there, but in fact, it's the prediction interval that matters. And you've got this huge prediction interval. And so you've got there's this illusion of precision around modelling performance, and it is an illusion. It's not there. And that's been part of the problem, I think, is that we haven't been able to distill that there's this huge heterogeneity and we don't actually know, is what I would argue. One way we looked at testing this was looking at the subset of contrast-associated acute kidney injury. And we had the good fortune there that there was a meta-analysis, a good systematic review rather. They didn't go on to meta-analyse the data because of the heterogeneity, done by Ron Wald and colleagues, again from Canada. And that was published in 2015, and they had around 12 models. Again, they hadn't meta-analysed that data, but there was a point in time where we knew there were these models that were extant, and that was a point that we could move forward from. And we effectively updated that meta-analysis. And consistent with the expansion of the literature, the number of published models had more than quadrupled in the space of 7 or 8 years. And again, we asked the question, well, have we got further because of that? So what we've done here is the block down the bottom is the 2015 data, which we then meta-analysed. And up the top is the stuff we did. And if you plot the summary ROC curves of those models, they look very much the same. So in terms of the performance of the models, they look broadly the same. Again, and in the dotted lines in the middle, the blue one is the old meta-analysis confidence interval. And you can see it's reasonably broad. And with the addition of new data, that confidence interval is narrowed quite substantially, and again gives this illusion of precision. But if you apply a prediction contour approach to it, you can see the prediction contours haven't changed at all. So we're 8 years down, quadrupling of the literature, and we know no more. One of the challenges in this space is the fact that very few of these models are externally validated. And it's difficult to do. A lot of them are bespoke models or opportunistic models in that they've got a data set that sits in one hospital, they do the analysis and they publish it. And the data set in hospital B doesn't look quite as tidy, and so it can't externally validate it. So the external validation is hard. Again, one of our opportunities here was that we had access to the PRESERVE study data. So the PRESERVE study was a big RCT testing N-acetylcysteine and sodium bicarbonate for the prevention of contrast-associated acute kidney injury. So we were part of that trial. We had the data set with the Americans. So we then looked at a series of models that used variables that we had that data for. And so we could externally validate those 5 models against the PRESERVE data set. And PRESERVE was prospective RCT, very regulated, good quality data. So it was an ideal opportunity. And again, when we put them on the summary ROC curves, they're not the models turn out to be not much better than the toss of a coin. So the models don't work. And that includes the Mayrin model, which is probably the most widely used in this space. Again, none of them are widely applied, but most people use that as a sort of reference point. But again, in a population recruited to be at high risk of acute kidney injury from contrast, it didn't add much. So the next step we took was around trying to develop an AKI prediction model in a setting where the risk is high. And I would argue that ICU is actually the place to be here, because the event rates for acute kidney injury in the contrast space and even in the cardiothoracic surgical space, I think are pretty low these days. So Yunlin set out to put together a multivariate model using data from the CHEST trial. So the CHEST trial, big RCT of patients coming into ICU needing fluid resuscitation. So high risk for acute kidney injury. And we had good baseline data because as they came into the unit, they came in early. And you can see that the variables that constituted that model, none of which would surprise you too much. But the interesting thing for me was that the transfers from other hospitals had a much higher risk of acute kidney injury. And I suspect that's just because they've got to be sicker if they're coming from somewhere else. And they've also had longer to brew and get their acute kidney injury. And when we put together that model and we looked at its performance, it was pretty reasonable. So we ended up with a C statistic of around 0.72. And we had a few different models which we tested, which were all pretty similar. Then, again, we had the opportunity to externally validate that data. So the PLUS study was very similar to CHEST. It was a fluid resuscitation study done in ICUs early on in their stay. And then Yunlin sourced one of the more typical data sets that get used in these modelling approaches, and that was a administrative collection within the ICU setting in a Chinese hospital. And we tested how that model might work in those two different settings. And you can see with the PLUS trial data, we've got a very similar population coming into ICU, the performance is very similar to what we had when we developed the model. So externally validated, this model works well in that population. And in the Chinese ICU population, it doesn't work at all. Again, because of those, the case mix differences and the lack of formal definition about who goes into a clinical trial. So, in summary, there's lots of models out there. I think, unfortunately, they're not used. The heterogeneity is rife in this sector, and we need to get away. We need to be careful about interpreting confidence intervals and talk about prediction intervals. The external validation is rare, and that's probably the most important thing to do in this space, I think. And I just to be pedantic, I say emphasis matters. So the title of my talk was, "Can we predict AKI?" I think if you ask me, can we predict AKI? I would say no. But can we predict AKI? Yes, I think we can. So it depends upon your emphasis. So where to next? Well, I think we've got to be talking the same language, and we're not at the moment. So we need to focus on patient groups at highest risk of harm. And they're the ones with more severe acute kidney injury. So I would argue, the stage 1 acute kidney injury of 25% increase in serum creatinine is meaningless, and we shouldn't be using it in this literature. And the population group that I think is the best opportunities is the intensive care groups. We need high event rates, and that makes studies in contrast associated with acute kidney injury problematic, because I think the rates of harm there are minimal. I'd love to do a trial to randomise patients to contrast or no contrast in coronary angiography. I think that's the only way we'll ever get the answer to how big an effect that has, but I don't think the cardiologists would ever let us do that. And we need to find patients early in their journey, because this is a time-critical illness, and that's why it's generated so much heat and noise, was because things go off quickly and you need to be intervening quickly. But the key bit to this, I think, is defining the populations. And we need to be doing that like it's an RCT. It's so that we do comparable studies. All the studies in glomerulonephritis is tightly define their populations, and that's where we need to be playing, in where we can. An ICU population in Colombo is the same as Perth in Australia. We can pick out a subset of patients, and we're all talking the same language. And what that will allow us to do, which we haven't been able to do to this point, is that we can actually incrementally improve. So that if I'm in Australia and I develop a model in a population that we all agree on, and we put a variable into that, it's published, then someone else can come along and say, well, I've got exactly the same population. I'll add this variable into it and look how this model changes. We're incrementally improving. At the moment, we're not. We're just throwing stuff at the wall and seeing what sticks. And I think there's a role for specialist societies and guideline groups and others to sort of give some structure to that. So I'll leave it there. I'd like to acknowledge especially Yunling Feng, who's done an amazing body of work. Hopefully her PhD flies. And there's lots of other collaborators and people who've contributed data from studies, etc. So thanks.
So it was a changing phase. So we'll start with the lexicography, that is called nomenclature of the AKI. In 1802, William Haverden termed it ischemia urinalis. That means cessation of the urine. In 1909, Osler's textbook of medicine, it was termed as acute Bright's disease. Every time World War has taught some lesson, during the First World War, it was termed as the war nephritis. During the Second World War, it has been associated with the Crush syndrome. And for many years, ATN and ARF was interchangeably used. It was Homer Smith in 1951, first time coined this term acute renal failure in his textbook. And in one of the survey, that has been published in 2002 was showing 35 different definitions of the AKI. Some was defining as rise in this 0.5, 1, 2, up to the 2 milligram rise in the serum creatinine value was defined as the AKI. So that was the varying definitions. Classical, when you talk about this classification of the AKI, that we all have read since our MBBS days was the acute kidney injury, that might be the pre-renal, renal or post-renal causes, and all 4 compartments can cause AKI, like the tubular damage, glomerular damage, interstitial damage or vascular damage. All can cause AKI. In the tubular damage, which is the most specific region of the AKI, most common causes is ischemic and it might be the toxic. When you look at the acute tubular necrosis part, it might be ischemic and toxic. Toxic, it might be endogenous or it might be exogenous. Endogenous, we all understand about the myoglobin and hemoglobin can cause acute kidney injury. Exogenous, drugs, diets, some of the organ solvents, fish gallbladder poisoning, that can cause the toxic ATN. That is very common in our parts of the world. Then again, the different causes of the AKI depending upon pre-renal, renal and post-renal causes. Then classification of AKI evolved to bring the uniformity in defining AKI so that the literature should be the same evidences. In May 2002, ADQI came up with the Rifles criteria. 3 risk, injury and failure was the AKI severity depending on the severity, and 2 was the outcome criteria, loss and end-stage kidney disease. And subsequently there were a lot of flaws in this definition. If you do not have the baseline known, what you can do? Then AKI criteria came in 2005 in Amsterdam. There was one group of the critical care medicine nephrologists, all those are involved in critical care. They came up with this definition of the AKI criteria, and again they have removed the loss and end-stage kidney disease, L and E, and keep depending on the severity, stage 1, 2 and 3. And 2012, KDIGO came up with a strong definition of the AKI which is followed worldwide. So now the emerging concept of the AKD came up. So AKI falls within the circle of the AKD, and there is overlapping features of AKI, AKD and CKD. And many patients of the AKI or AKD may progress to CKD. So within 7 days duration AKI, 7 to less than 3 months AKD, and more than 3 months CKD, that all everyone know about this. And most of the times you can only identify the markers of the kidney damage. What are the markers of the kidney damage of the AKI? That might be albuminuria, hematuria and pyuria, particularly in AKI. In CKD, it is possible that you might have the only markers of the kidney damage like the albuminuria, but you might have the microscopic hematuria as well. So stages of the CKD depending on the severity, what you can see. This is one of the very important slide here at risk. You have the AKI which can only be identified by some of the biomarkers like NGAL, kidney injury molecules, TIM, or insulin-like growth factor binding proteins. Then the same thing, stage 1, 2 and 3. AKD has some staging. Stage 0, A, B and C, and then stage 1, 2 and 3, there was no much difference as it has been defined in the KDIGO 2012. So stage 1, if you have 0.3 milligram rise in the serum creatinine or 1.5 to 1.9 times. Stage 2, if 2 to 2.9 times from the baseline, if more than 3 times baseline, it can be stage 3. So what is ABC0A? When there is no OA, when there is no evidence of injury, if there was loss of renal reserve and serum creatinine did not come back to normal, then it is called AKD stage OC. But we all understand what has been proposed, that if you do not have the baseline, you can take GFR of 75 ml per minute calculated by MDRD equations. That has come into the literature. But we all understand MDRD equation has been validated for chronic kidney disease, not for acute kidney injury. So you need to calculate it by kinetic eGFR, and there is complex formula. I am not going to spend time here. So cellular pathophysiology of the ischemic ATN, when you look at in the center, there is generalized or localized reduction in the renal blood flow, and your causes might be hepatorenal, cardiorenal, loss of the blood volumes, might be the renal vasculature, glomerulonephritis, or medications, but all that leads to acute kidney injury. So pathophysiology, in the base, there is decreased circulatory volume. So you have activation of two important receptors, baroreceptors and osmoreceptors. Baroreceptor activations leads to increased norepinephrine, increase in angiotensin 2, and both leads to increase in norepinephrine, renal vasoconstriction, decreased GFR, angiotensin 2, increased aldosterone secretions, increased sodium water retention, and osmoreceptors, increased diuretic hormones, so retaining a lot of water from the collecting duct, so decreased urine output. But vascular effect is more important here. That has been later on emphasized too much. Vascular effects, you might have the endothelial cells injury, decreased endothelial nitric oxide, increased endothelin, and decreased prostaglandins, all again leading to decrease in the GFR. So classically we know this macro photographs, what we can see here, the blood supply. We all understand since our MBBS days, outer medulla is too much rich in the supply. So they are at the most, and most of the active pumps are there in that region, thick ascending loop of the Henle requiring ATP. So this is the area most vulnerable, and most of the times the small arterioles vasoconstrict more than the other normal kidneys. So whenever there is ischemia, glycocalyx of the endothelial cells gets disturbed, gets injured, and once that injury happens, then there will be leakage of the endothelial cells into the interstitial space. So T cells, neutrophil, monocytes, and platelets all can come into the interstitial space. There would be increased number of the dendritic cells, and there would be extensive interstitial edema. At the same time, platelet aggregates to the endothelial cells, injured endothelial cells, and you might have the microthrombi, further aggravating the injury. This is the electron microscopic photographs where we can see the second panel, the macular degeneration of the endothelial cells. Then there is thickening and multilayering of the membrane formations. Here we can see on the E panel, and then you can see on the F panel, in the interstitial region, the attachment and penetration of the monocyte-like cells. That happens, that has been demonstrated in this here. So it looks like AKI is more of the inflammatory disease. What we can see here, there is a loss of, whenever there is a ischemia or reperfusion, there will be loss of the polarity. Sodium, potassium ATPase, which adds the basal part of the tubular epithelial cells that go to the apical part. So there will be loss of polarity, and some of the adhesions molecules will at the base membrane go to the sides. Then cell death happens. Necropsis or apoptosis can happen. There will be dehiscence of the tubular epithelial cells that can block the tubules, might be increased pressure in the tubules. Then the rest of the viable cells can have the dedifferentiation and then proliferation, and they can restore the normal epithelium. So that is the usual phenomenon. But at the same time, when the injured tubular epithelial cell secretes a lot of the inflammatory cells, and the inflammations go on. It is not only the vascular cells, it is the tubular epithelial cells also which secretes a lot of the inflammations and cause inflammatory injury. There are different, we all understand about the apoptosis, programmed cell death, which is the most common pattern of the cell death in AKI. But it is not only this apoptosis, ferroptosis, necroptosis, pyroptosis, and you can have the autophagy. What is important to note? Only apoptosis inhibits inflammation. Rest, all of the types of the cell death are promoting inflammation. So it promotes inflammation. And now, this is the one recent article published in Renal Physiology, American Journal of Physiology, where we can see the directed depending upon the cell death, you can direct the therapy. There are many interventional therapy which are under the research and might be the future for the treatment for the AKI. So normal tubular epithelial cells, then you might have ischemia reperfusion, migration of the T cells, macrophages and neutrophils into the interstitial space, then myofibroblast, and finally what happens if usually whenever ischemia there will be cell cycle arrest. Cell cycle arrest happens in G2 and M phase and cells try to repair themselves. DNA repairing happens. If there is a prolonged ischemia, it is possible that you might have the chronic hypoxic conditions, might be aggravation, decreased sodium excretion and hypertension, prolonged cell cycle arrest, all leads to some pattern of the change in the healing. So there would be the chronicity. So there would be the change of the monocytes to myofibroblasts, macrophages. Some of the epithelial cells have the epithelial mesenchymal transition and you might have the more myofibroblast. So healing would be the maladaptive. So you might have the two kind of the healing. One is the adaptive repair. So normal tubules, you might have the maladaptive repairs, and this maladaptive repairs when you have epithelial mesenchymal transitions, conversion of the many of the cells into the myofibroblast, then fibrosis happens, interstitial fibrosis, and if you have the maladaptive repair, many of the abnormal tubules gets atrophy and atresia. So it is important to understand about the degree of the injury, degree of prolongation of the ischemia, and injury of the vascular injury that actually determines the course of the AKI. So sepsis is another important reason, so I would like to touch this. Again, here we can see there are two compartments, renal endothelial cells and renal tubular epithelial cells. In the center, what is there? DAMPs and PAMPs activates endothelial cells, dysfunction, apoptosis and paroptosis, activation of the macrophages, monocytes, and finally inflammation. Again, here we can see on the tubular sides, mitochondrial dysfunction, again tubular epithelial cells, apoptosis, necroptosis and paroptosis, again promoting inflammation. So it looks like not more of the tubular injury, it looks like more of the inflammation. And even tubular cells also contributes in aggravating the inflammation. So this is one of the pioneers who worked in the AKI in 2004 when I was a resident. He came to India. He had presented this NEGM articles. You can see this is still valid. And we all understand sepsis, bacteremia, endotoxemia, increased endothelial nitric oxide synthetase. So increased nitric oxide synthetase, arterial underfilling, baroreceptor activations, and finally renal vasoconstriction, sodium and water retention. That is the clinical manifestation of the AKI. Many times we must have encountered whatever you do, your patient do not respond to vasopressor. Why this happens? This happens because increased lactic acids, increased hydrogen ion enters into the endothelial cells or smooth muscle cells of the vessels, and potassium comes out. So there would be hyperpolarization of the vessels, and hyperpolarization leads to vasoplasia, and at this stage whatever you will do, patient is not going to respond. So that kind of the sepsis severity we should understand, and that we all encounter in our day-to-day practice. So depending upon the sepsis and severity, you might have the different clinical phenotypes. One of the study has shown delta phenotype, which is the most inflammatory state of the sepsis and very procoagulant. They have shown AKD progression in 41% of the patient as compared to the alpha type, which has the least inflammation, only 8%. So this all depends on the severity of the sepsis. Physiologically, when you look at the physiological course, you must understand here what we can see. Initially, during our MBBS days, phase of extension was not there. Phase of extension means macrocapillaries injuries, and there endothelial cells gets dehiscence from their basement membrane and blocks the small capillaries, and these capillaries and prolongation of the ischemia determines the future course of the disease. So here the vascular injury becomes more important. All AKI are not the same. So this was the one mouse model study where they have tried to understand ischemia induced or volume depleted AKI. In ischemia induced and volume depleted AKI, we can see transchromed variations. What we can see here, in outer medulla, more than 4,000 differentiation in the ischemic transcriptomes as compared to only 81, and there was minimum overlap of 93. And what they have tried to show, when there is volume depleted, this heat map shows volume depleted TCA cycles, glucogenesis and transport of iron and amino acids are affected. Whereas ischemic, you have the more of the cytokine activity, more of the fibrin clottings, more of the microthrombi formations. That kind of the genes can be activated. So all AKI are not the same. Multi-organ dysfunction syndrome might be different, and isolated AKI might be different. This is our Indian evidence for that our chair was talking about. So what we have seen in our one of the community acquired AKI, more than 3,700 patients, what we can see at the end of the 3 months, at least 7% of the patient did not recover at all, and 1% of the patient remains dialysis dependent. That has been published in Lancet Regional Health. Another evidence we can say here, this was the COVID-19 patient, about 3,000 patients admitted to our ICU. 951 patients had AKI. Mortality in patients with the AKI was 42%. And what we have observed, residual kidney damage remain there in 5% of the patients at the end of the follow-up. So AKI to AKD transitions to CKD is important. Biomarker of the non-recovery of AKI, CCL14, fairly predicts ability to non-recovery. And TIMP is a tissue inhibitor of metalloproteinase and insulin-like growth factor binding protein 7. When you combine together with some clinical biomarker, AUC of prediction of the non-recovery becomes 82%. So we should study now which patient is likely to progress to AKD. Pre-op urine, DCOF and creatine, that again predicts. DCOF is a marker for the epithelial mesenchymal transition and fibrosis. So if we have this lab facility, we can determine with this DCOF and serum creatine that this patient is likely to progress to the AKD or CKD, or there is chances of the persistent AKI. CCL14 I have already talked about. So more than 13 if CCL14 as a novel biomarker for the persistent AKI, then 10 times higher chances of persistent AKI is there. So for the clinicians, nothing to do. What we have to do, identify the susceptible factor, exposures, find out the many of the pathways are activated, like decreased renal perfusion, hypoxic injury, endothelial dysfunction, oxidative stress. So many factors are there. So that remains the part where we should understand and remember. So take home message, all AKI are not the same. Ischemic and volume depleted AKI are not also different. Cell death in AKI and ATN may also happen because of apoptosis, necropsis or ferroptosis. Vascular damage drives the course of the disease. Community acquired AKI also may progress to AKD.
I'll be talking about the tailored care for AKI, what we should do as clinicians. AKI is being highlighted. It's very common in the community and in the hospitalized patients as well, where it's around 20%, and in patients in ICU, up to 50%. So remember, whatever specialties you are practicing, you will encounter AKI, and all of us should know the basic principles of management. Non-dialytic, how much fluids to give, when to give, what to give, and dialysis, at least when to start and what modality and when to stop it. So let me begin with a case. We have Mr. P, who is a diabetic, hypertensive, diabetic kidney disease. His last known creatinine 3 months ago was 1.8. He was on metformin, telmisartan, atorvastatin, and dapagliflozin. This is what he told. And he had a history of fever, dysuria, now admitted with hypotension. On examination, JVP appeared normal. There was no edema. Lungs were clear. Blood pressure was 87/50 with a mean arterial pressure of 63. So how do we manage this patient? The first step is have a look at the patient. Quick history and examination is never amiss. So this patient had a history of fever since 1 week and had oliguria as well. You also look for some of the clinical features which may help with the etiology, jaundice, bleeding, livido, splinter hemorrhages, so on and so forth. So 1 minute for this, and the next minute, what do? You try to send off the routine chemistries, measure a lactate level, obtain 2 sets of blood cultures in this patient who seems to be having some form of sepsis AKI on a background of diabetic nephropathy, and administer broad spectrum antibiotics. So as per the unit protocol, after taking a physical history examination as well, these parameters were sent and the patient was started on piperacillin tazobactam, depending on the culture sensitivity pattern of our unit. The reports came back, lactate was 8, which was elevated. He reported a urine output of just 100 ml. The sodium was 137, potassium 5.5, creatinine was 2.1, bicarb was 14, hemoglobin 11, and total count of 32,000, and he had markedly elevated CRP. So the common question asked, the patient is in hypotension, doctor, should we give fluids? What would you do? So till some time ago, we were practicing fluids, early goal-directed therapy. We were taught, give fluids to achieve a predefined physiological endpoint, a urine output of at least 0.5 mils per kg per hour, CVP more than or equal to 8 millimeter Hg, and central venous oxygen saturation above 70, and try to bring lactate to normal. And this is what we were practicing, and we ended up giving up to 5 liters within the first 3 hours most of the times. This was by Rivers et al., published in NEJM long time ago, and this was we were practicing few years ago. But then we had more trials, the ARISE, the PROCESS, the PROMISE, and the classic trial. And what did these trials tell us? Early goal-directed therapy may not always be good. Practice a more restrictive therapy. The early goal-directed therapy, liberal therapy, may sometimes lead to worsening outcomes, even worsening AKI. And why did they say that? The concept was hypotension is not always equal to a fluid deficit. The blood pressure may be low despite the patient being in fluid overload. This may occur because of maybe capillary leak in the cases of sepsis. And what they said is look for other signs of overload in the patient, that is increased pressure in the renal veins, in the portal circulation. Look for abdominal compartment syndrome, which we often miss because all these compromise the renal circulation. Finally, worsening AKI. So more fluid, more interstitial fluid, and you have increased pressure leading to decreased renal perfusion. Fine, then how do we plan the fluids, less or more? How do we determine the sweet spot in fluid dosing, where we do not create organ ischemia and we avoid overload as well? How do we do it? So now the guidelines say, apart from a history and physical science, which we did already, and the biomarkers of perfusion, which we do, lactate and the electrolytes, the urine electrolytes, look for imaging, including X-ray, echocardiogram, for IVC collapsibility, cardiac output, bedside assessment, and look at the Doppler of renal vein, portal vein, and a point-of-care ultrasound of the lung. These have become very useful tools for static measurement and also dynamic measurement of the fluid volume. So this patient, where we had a clinical suspicion of hypovolemic AKI, we looked at the bedside echo, which showed a low cardiac output. The IVC collapsibility normally should be less than, the collapsibility should be good. The distensibility normally should be more than 18%, but in cases of overload, the diameter may be more than 2 centimeters and the distensibility would be less than 18%. Venous excess ultrasound score, which depends on the Doppler of portal vein, the renal vein, what does it show? Normally, it should not show any pulsatile pattern. Pulsatile pattern indicates overload. And lung ultrasound, we are very familiar now. Horizontal lines is a happy thing, whereas the vertical lines the lines extending perpendicular to the rib cage more than 10 centimeters, they indicate lung fluid. So they are called the B lines, which often replace the A lines. And remember, if you still see a collapsed IVC, but distended bowel or fluid in abdomen, be suspicious. This patient could be overloaded. So what happened to our patient? Let us see. So if the Vexus shows a dilated system, obviously we don't give fluids. But in our patient, there was no dilatation. We did a fluid challenge test, which showed that the patient was fluid responsive, responded to the fluids. In case there is no fluid response, we don't give fluids. But because our patient was fluid responsive and a low MAP, we decided to give fluids. Fine. So having decided to give fluids, what fluids do we go for? Obviously, choose fluid which stays in the intravascular compartment, and we know that the colloids and crystalloids stay in the intravascular compartment, whereas the dextrose moves away from the intravascular compartment. So out of the colloids or crystalloids, which is the way to go as per the latest update? It says crystalloids are the way to go as compared to colloids, and there are several studies which were alluded to by the first speaker as well. Out of crystalloids, which crystalloids then? We know that normal saline is rich in chloride, and in this way, it might cause renal vasoconstriction. So, balanced crystalloids, that is plasma light or ringal lactate, may be better. In low resource setting, however, normal saline can still be used. So, our patient, we decided on balanced crystalloids based on the evidence of so many trials listed there, the SALT, the SMART, the SPLIT, which clearly showed that balanced crystalloids are the way to go. So we did give fluid replacement for the patient, and we repeated the ultrasound and the Vexus, and after 1500 ml, the IVC was non-collapsing, but the MAP still was stuck at 63 millimeters Hg. So what should be our target MAP in this patient? We know either equal to or more than 65 mmHg as per the previous guidelines, but subsequently several trials have shown that it might be better to aim for a higher MAP in patients who are chronic hypertensives. So this was the sepsis PAM trial along with other trials, the Finicky trial, the Fedora, which said higher MAP for patients who are chronic hypertensives. So in our patient also, we targeted a higher MAP. The MAP was 63 at the end of fluid resuscitation. And where do we go from here? We choose vasopressors. Now, there are multiple vasopressors available. Which one to go for? So the clinical evidence is not very clear, but most of the papers say the drug of choice is norepinephrine. And if still not responding, you can add vasopressin. Dopamine has gone out of favor because of the risk of arrhythmias. So our patient was put on norepinephrine and later on vasopressin. What about role of corticosteroids? The guidelines again are not in consensus, but it is said that patients non-responsive to vasopressors, what do? Refractory shock, you can go for a stress dose of corticosteroids. Hydrocortisone is generally the drug of choice. What about diuretics in our patient? We know that if the patient is not clinically overloaded, no role of diuretics. If you have to give diuretics for overload, give IV, give loop. Bolus or infusion, both are okay. Toracimide, furosemide, both are okay. But do not use to prevent or treat AKI in the absence of volume overload, because it may worsen the electrolyte abnormalities without causing any renal benefit. And a paper AKI 18th by Dr. Kher et al. Has shown the role of furosemide stress test, where you may give 1 milligram per kg of furosemide and look for the urine output in the next 2 hours. So if it's more than 200 ml, then the chances of renal recovery are high. So diuretic can be used for that furosemide stress test and for overload, but not otherwise. Our patient did not receive diuretics. Mannitol, again, routine administration is not to be favored. The patient was taking orally, so he was on enteral nutrition, which is the way to go. In case enteral is not feasible, parenteral can be given with calorie of 25 to 30 kilocalorie per kg and a protein of 0.8 to 1 gram per kg per day. If the patient goes for dialysis, obviously we need to up these targets. The nutritional assessment may not be accurate. You have to look at clinical as well as biochemical parameters. What about the drugs? So our patient, we know the first rule in AKI is to avoid the sick day rule drugs. So the patient, metformin was stopped, SGLT2 was stopped, as well as the telmisartan. It's advisable not to add potentially nephrotoxic drugs, and whatever drugs you add, you adjust dose as per renal clearance. So our patient was put on insulin, was also put on piperacillin tazobactam. What about the antibiotics? So antibiotics, the baseline is you go for the simpler one, generally either ampicillin, amoxicillin clavulanate, and aminoglycosides. Our unit protocol, we had given piperacillin tazobactam. You would wonder why aminoglycosides? What's the latest on that? So single dose of aminoglycoside for a peak effect has not proven to be deleterious even in cases of AKI and can be used in resource-limited setting. It's a very good bactericidal antibiotic with a low cost, and resistance is very less to that. So whatever antibiotics you give, be familiar with the renal dose modifications, the effect of antibiotic by the renal replacement therapy. So peptides, we have given piperacillin tazobactam. Again, loading dose has to be given, followed by altered maintenance dose and post-dialysis dosing if the patient goes for renal replacement therapy. So these should be looked at. Therapeutic drug monitoring is many times not available even for the drugs with low therapeutic index in LMIC. And we can just look at the clinical signs. So this was all done on day 1. The patient passed into day 2 pretty much stable. The infection parameters were coming down. There was a slight rise in creatinine though. The vasopressors were continuing. We passed into day 3, and day 3 brought another challenge, potassium 6.1 with tall T waves on EKG. So the patient was given medical management of hyperkalemia at that point of time, which is indicated if the potassium is less than 6.5 with ECG changes, or if you have a potassium more than 6.5. And we are quite well familiar. The patient was treated with calcium gluconate and insulin dextrose drip as well. And you can go for bicarbonate or furosemide. So these can be done. What about bicarbonate therapy for our patient? So there is no consensus. Only if the patient has high anion gap metabolic acidosis, there are some papers to support bicarb therapy, which is given at a dose of 2 to 5 milliequivalent per kg, single dose over 4 to 6 hours. However, many papers are against that because it causes overload, rebound alkalosis, and decreased oxygen delivery to the tissues and even hypocalcemia. So day 4, the oliguria was continuing. We have finished 72 hours of non-dialytic therapy. The patient was stable, but potassium was along the upper limit. Again, it was 6.2. So we decided about renal replacement therapy for this patient. When do we consider renal replacement therapy? It's obvious if you have the 5 emergency indications, go for it any time. Day 1, day 2, day 3, doesn't matter. And what are these indications? AEIOU, intractable acidosis, intractable electrolyte abnormalities, inorganic poisoning, overload, and uremic encephalopathy or pericarditis. So these can be emergency indications. Our patient did develop hyperkalemia, but it was managed medically. So what are the other indications if there are no emergency indications? So many of the trials have shown that late initiation is also fine. The definition of late is different in different trials, but overall more than 72 hours, if the still AKI persists, that would be the time to start. ELANE was the only positive trial which showed early dialysis may be better, remaining all said. Dialysis later was also fine, and our patient was subsequently started on dialysis on day 4. And this concept has come because you have to individualize for each patient depending on the demand, the capacity of the kidney. You can tailor your dialytic therapy, when to start and when not to. Fine, having decided dialysis, which modality? All are available. There's a beautiful paper by Dr. Lobo, who is one of the chairpersons here, who has defined the different attributes of different therapies. We all know hemodynamically unstable patients, and especially the patients who are on other extracorporeal therapies or have a raised ICP or liver disease, go for CRRT. Otherwise, all other therapies are equal. Vascular access and anticoagulation are problems with blood-based therapy. PD, you don't need that, but PD has a lower solute clearance. PD is, however, very cost effective. SLED also is a very useful therapy in LMIC settings and should be used more often. So there is no significant difference among all modalities of dialysis regarding outcomes. And what do the guidelines say? KDIGO says, go for CRRT only if hemodynamically unstable, acute brain injury, increased ICP, or acute liver failure. Otherwise, all are equal. And the 17th consensus statement by AKI by Dr. Kher again states the same. Depends on your expertise and availability. Do what you are comfortable with, and situations where other extracorporeal therapies are required, for instance, ECMO, CRRT would be the better modality. So our patient, we started on CRRT, we have it available freely in the setup, and that day we could not arrange for SLED, but otherwise SLED is very, very useful. Our patient was on CRRT for 16 hours. Slowly the metabolic milieu normalized and the urine output started increasing. So day 5, the pressures are better, the counts are better, the output has increased, and it was time to discontinue the therapy. So our patient passes through all the 4 fluid stages of AKI: resuscitation when we gave fluid, resuscitation, optimization and stabilization where there were no external fluids given, and de-escalation when we remove fluid from the patient by doing RRT. Just to say that stiff catheter PD also is being done in our center. It's a high volume center in a government hospital and it has very good results. So our patient, the CRRT was discontinued on day 5 and the patient was shifted out to the step down care. So specific therapy of AKI for this patient was antibiotics, but you may need different specific therapies depending on the different causes of AKI. And if the patient goes for a contrast study, the latest guidelines say low volume, lower isoosmolar contrast is fine, hydration is fine, and the PRESERVE trial alluded to by the first speaker says that no role for N-acetylcysteine or bicarbonate. Avoid concomitant nephrotoxins. Fortunately, our patient didn't need a contrast study. Dr. Narayan has also talked about the biomarkers of pathophysiology, and there are other newer biomarkers. There's a whole list of them. But remember, this is for the students and as of now under research and not in clinical use. So what do? We discharge the patient on 10th day. Follow-up is important, ladies and gentlemen. You'll be astonished to know 75% of patients with acute MI are followed by cardiologists. But where are the nephrologists? Only 10% of patients with acute kidney injury are being followed by us. That's a dismal figure, and we need to change that definitely. Because AKI, AKD, CKD is a continuum. 20% of AKI patients land up with CKD. We have high morbidity, mortality. So do you not think that it is our duty to follow up these patients? And this is what we are not doing and we can improve upon. So, ladies and gentlemen, I would conclude saying that acute kidney injury is quite common. Community-acquired kidney injury is very common in our settings, which was alluded to by Dr. Narayan. Here, the treatment practically remains the same. It's generally related to gastroenteritis and infections. It's mostly volume responsive. The dengue, malaria, they can be treated the same way with specific treatment for malaria. Fluids can be given oral or IV, and recovery occurs if you identify and treat early. So what would I say last? We have different types of AKI. The principles of management remain the same. It's a very common problem. Like it or not, you are going to face it. So learn to treat it properly. Most cases may not require renal replacement therapy. Proper fluid balance, attention to antibiotics, nutrition, drug dosing, metabolic milieu is important. Overload, remember, is an important cause of morbidity and mortality, and the focus has shifted from too much fluid to appropriate fluid. And you have tools at disposal. A bedside ultrasound is a very useful tool to have in your unit. And if we need RRT, if you have the AEIOU of emergency dialysis, or if the recovery is delayed, you always have RRT. All modalities are equal. Don't go for the fancy one, but what one you are comfortable with. And once you have successfully treated and discharged the patient, long-term follow-up is essential. So thank you, ladies and gentlemen, for the opportunity, and thank you for a patient hearing.